Good evening, everyone, and thank you for joining us for another International Dermatology Education Foundation educational series. I'm Leon Kircik. I'm the president of International Dermatology Education Foundation, as well as a clinical professor of dermatology at Icahn School of Medicine at Mount Sinai in New York City, also Indiana University Medical Center in Indy. Also, I have my private practice and clinical research center in Louisville, Kentucky. Tonight is very unique. We're gonna do something that we have never done before, and I'm not only the moderator tonight, but I am the host and I'm the speaker. And that's because it's a very special program that I feel very near and close to my heart. We're gonna discuss a new pathway that we never knew about it before. It's gonna be neuroimmune pathway underlying the pathophysiology of Prurigo nodularis and atopic dermatitis. So I'd like to thank, if I can move our slide, a couple of housekeepings. First, I'd like to thank our supporter Galderma for making this program possible tonight. And before we begin, if you're having any issues hearing the webinar, please, you can listen to the presentation using your telephone. Just select the phone call in the audio pane and dial-in information will be displayed. If you have technical issues, recently we have some, as you know, because of the outage. And if you'd like to submit a question to our faculty, please submit your question in the questions pane on the right-hand side of your screen. Also, at the end of this webinar, a survey will pop in your browser and will be emailed to you within 1 or 2 days. We would greatly appreciate if you could fill out this very short survey. Within 1 or 2 days of the webinar, a certificate of attendance will be mailed to you. Now, again, remember at the end, when we have some time, we'll be able to answer all the questions and use the questions pane on the right-hand side of your screen. Before we go any further, a couple of words about International Dermatology Education Foundation. It is a non-profit organization, and our principal mission is to raise awareness and improve dermatology care all over the world through education, especially in underserved areas. And we have served since actually the pandemic. We have done webinars all over the world, not only in US, but in Canada, in South America, in Southeast Asia, as well as Europe. And some examples of our previous educational sessions are here. Also, please follow up and stay up to date with our LinkedIn, as well as Instagram and Facebook. So, as I mentioned, we're gonna have a very special program tonight, and I will be speaking on this bridge that puts Prurigo nodularis and atopic dermatitis sort of on each end of this bridge. And it's a very interesting concept. And we know a lot about atopic dermatitis, but the more we're learning, we find out that the less we know about it. The other disease entity we will discuss is Prurigo nodularis. Prurigo nodularis itself, it's nothing new, but now that we have some treatment options and some are coming in the pipeline, we are very happy to discuss this disease entity, but more importantly, really, what is the pathophysiology and what's the link between those two diseases, atopic derm and Prurigo nodularis. Now, remember, it's a Galderma-sponsored program. This presentation is intended for interactive scientific exchange, and also discussion will be limited to the content of this presentation and should not include any clinical data or competitor products. So when we look at atopic dermatitis, we see it almost every day in our offices. I just came back from the office actually, and you know, in one day, probably I see more than 10 atopic derm patients. Some are new, some are old, and we certainly interact with those patients. We know their disease manifestations, but it's really interesting how certain disease manifestations and the burden of the disease is very similar to the Prurigo nodularis patients, right? And we're gonna try to find the pathway, the shared pathway between those two diseases, because then the treatment options become very relevant. So when we look at the disease manifestation and impact, and we'll start with atopic dermatitis, I think we all can recognize atopic dermatitis. We know the lesions, the erythema, the erosions, the papules, pustules, the oozing, weeping, right, the scaling. And then the distribution of the disease, by the way, it's very interesting. It's a very heterogeneous disease. The morphology changes with the age, right? When we look at the infancy and then maybe toddlers, you see that the disease is mostly on the extensor surfaces and mostly on the cheeks. And then as the patients get older, the morphology changes. It becomes more on the flexural surfaces, less on the face. And it also, as the patients get even older, the disease severity gets worse. Now, some of the patients will get better and will lose the disease, but again, 25 to 30% of those patients, they end up with severe atopic dermatitis as they grow. And then it's also, we see more hand dermatitis, sometimes contact dermatitis, and all different forms and versions of eczema, basically. And we see that this is a very, very heterogeneous disease. Now, but when you ask them, when you ask the patients, certainly they will tell you that the most disturbing symptom of the disease, not only the lesions, but the itching. These patients are very, very itchy, very miserable. They cannot sleep at night. Sometimes they cannot go to work in the morning. And certainly it does have a high burden on quality of life, sometimes mental health disturbances, and also some non-atopic comorbidities. We also know that there are sometimes triggering factors. And it's very interesting. I see a lot of African American patients that actually they get worse in the summertime with sweating makes them worse versus mostly white patients that they get worse in the wintertime with the cold weather. The dry weather makes their skin drier and the flares become more often, more frequent during the wintertime. So really the manifestations of AD as the disease itself, it's very heterogeneous. It's also very several and various. Now, when you look at the demographics, and you see that almost 16 to 17 million patients, adults, have AD in US. For the last 20 years, we've been concentrating and focusing on psoriasis. We had several treatment options. Now we have more than 13 biologics in the market and many small molecules. And we have lost, I should say we have lost interest, but we did not have much interest in atopic derm. Even the atopic derm is a much bigger population than psoriasis, right? And so now that's coming back. It's almost atopic derm. It's like psoriasis on steroids 20 years ago, and we have so much evolution. We're learning so much new stuff on atopic derm, including the pathophysiology, but also we have so many biologics. We also have more in pipeline. We have small molecules. We even have topicals coming to the market on atopic derm, right? We have some recently approved. So when you look at the disease onset, again, we know that, and the perception is that atopic derm is a pediatric disease, which is true. We have a lot of kids with atopic derm, but when you look at the disease onset, in adult onset, it's almost 1 in 4 adults with AD have adult onset disease. And more than 55% of the adults with moderate to severe AD report inadequate disease control. And we're going to discuss this a little bit more in detail when we look at certain surveys and how the patients perceive the disease and how the providers perceive the disease. There's a huge discordance, and we'll discuss this a little bit later. Now, when you look at the age of onset, you see that about more than 20% is less than 5 years of age, right? But also there is a wide variety of adult onset, I should say 18 and above. You can see a lot of patients there above 18 that they have actually neo onset disease. More interestingly, I do a lot of clinical studies. I do a lot of atopic derm recently, and I have patients actually 65, 70, I think all the way up to 82-year-old patient I have put in the clinical studies. So it's pretty interesting that these patients are coming out of nowhere now that there's more options to treat them and we have clinical studies to offer them. It's very interesting that we are seeing more elderly patients. Now, this is a great slide in the sense that you see what I call many phases of atopic derm, right? What do I mean by many phases? As I mentioned, it's a heterogeneous disease. Morphologically, it's very different. I mean, look at the colors and the differences here. The lichenification is different in darker skin versus white skin. The erythema is different. It's interesting that erythema in black skin, it's more purplish, sometimes even grayish, different hues of the red. And in the white skin, you look at the excoriations versus the papules. Even there's some hypopigmentation sometimes with severe AD left over on especially in the darker skin. So there is a lot of different morphology and different locations of the disease, especially in adults. You see the palms, you see the feet, you see the hands. So it's quite interesting, the different versions, different morphology that we see in this slide. So that's why I really like this slide that gives us the whole idea of what I was trying to get across, that the disease is very diverse, it's very heterogeneous, and then you see very different morphology in many different patients. Now, the other interesting thing is that until now, we always, as providers, we believe what we see and we like to assess what we see. That's our nature as doctors, as healthcare providers, right? But how about what the patient's feeling, the subjective findings? And we are very much visual specialty. We look and we diagnose. But how about auditory? How about listening to the patient? How about the itch? How about the pain of the skin, right? So what we did was, this was a small study, close to 600 patients, adults with atopic derm, and they wanted to match the lesion severity to the itch severity. So they came up with 4 different categories, right? Mild itch with mild and moderate lesion, and I should say mild moderate itch to mild moderate lesion, mild moderate itch with severe lesion, severe itch with mild moderate lesions, and severe itch and severe lesions, right? And the whole purpose of this survey is to see how the itch, the severity of the itch, relates to the severity of the lesions, right? And most of the time, the impression is that if you have severe lesions, you're gonna have severe itch. Well, is that true? Let's take a look here. This is a little bit a complicated table, but basically they took the severity of the lesions either by EASI score, by objective score out, or IGA, you name it. But what we're gonna do is we will take just the first column, for example. If you take that 62% of the patients who have mild to moderate EASI score, right? And those patients also have mild to moderate itch. So here, that matches. But when you go to 24% of the patients who have severe itch, and these people who have the severe itch, they have also mild to moderate lesions by EASI score. So really what I'm trying to say here is that you don't have to have severe lesions in order to have severe itch. You can have mild to moderate lesional activity, let's say by EASI score here to 24%, but also have severe itch. And that becomes a big issue because we, healthcare providers, dermatology providers, don't see it the same way. And this discordant is almost obvious in most evaluations of how we treat patients. So let's take a look. The survey went one step further and asked the patients the patient perception of the severity, severe phenotypes, right? And basically what you see here, anything that has severe itch with severe lesions, or severe itch with mild moderate lesions, and mild moderate itch to severe lesions considered to be severe by the patient, all the pink columns. So what do you think here the providers are going to agree and will not agree with which column, right? Because the way we see things are by looking very visually, and I will say that if somebody has mild moderate lesion, probably doesn't have severe disease despite the fact that they have severe itch. And I'm gonna be correct because I cheated. I knew the answer. I've seen the slides ahead of time. As you see here, the providers, these are the crossed columns, right? That they thought those two columns with mild itch and severe lesion, and severe itch and severe lesion are severe diseases. But they totally ignored mild moderate lesion with severe itch. They didn't think that that is severe disease. And this is where the discordant is, and this always comes up, the perception of the disease severity by the patient versus by the provider usually doesn't match. And this is gonna become important as we understand the itch and the burden of the itch, and how we're gonna have a new treatment paradigm taking into consideration patients' subjective symptoms, especially itch. So let's think about that a little bit. When you ask the patients here, the atopic derm patients, what is the most burdensome symptom of AD? Itch is reported as the most burdensome symptom. More than 50% of the patients. Everything else comes later. Look at this. About 20% of the dryness and scaling. Everything else is less than 10%. The itch is the most burdensome symptom of atopic dermatitis. So now, let's go one step further, and what happens with that itch scratch cycle. So that itch scratch cycle will actually start and stimulate more inflammatory process. It will cause mechanical damage to peripheral nerve fibers. It will also cause what I call fibrotic changes or lichenification in atopic derm patients, as well as the prurigo nodules, formation of the prurigo nodules in Prurigo nodularis, right? That's where the name comes from. So it becomes a vicious cycle, and that itch is that central to the pathophysiology of both AD and PN. So if you ask the PN patients, very, very similarly to the AD patients, 50% of them, they have itch. Everything else, the visibility of skin lesions are about 22%, bleeding of the skin lesions is 14%, and everything else less than 10%. So the bottom line is here, the bridge that connects both PM and atopic dermatitis is, I should say, itch, the symptom of itch, and the heavy burden on patients' emotional and even functional well-being. So now let's take a look at a little bit deep dive into the prurigo nodularis itself, right? So we know about the presence of the firm nodules, papules, or the plaque lesions, and usually they are symmetrical. They spare the face, the palms, the feet, soles, scalp, and genitals. Usually patients scratch where they can reach, where they can pick, and that creates that vicious itch scratch cycle, which leads to that thickening, lichenification, fibrotic changes in the skin. And of course, the itch lasting more than 6 weeks, it's one of the criteria there. But the bottom line is the itch scratch cycle that becomes a really vicious cycle, and the patients cannot stop. And they describe that as not only an intense itch, but it's accompanied with burning, stinging, and sometimes pain. Well, demographics, about 120 to 143,000 US adults have prurigo nodularis. Ironically and interestingly, the African American patients may be affected disproportionately, almost 4 times more. And about 50% of those patients, they might have concurrent comorbid conditions. So when you take the itch score, right, and from 0, no itch, 10 being the worst itch, and you ask different patients, I should say different diagnoses, Prurigo nodularis 8.7 on that 0 to 10 scale, AD is 7.5, and urticaria is 7.2. And urticaria hives, we all know it itches quite a bit, but it turns out that AD is worse than urticaria, and PN it's even worse than AD. It's close to 10. It's 8.7. And also, it most of the time, more than 50%, you can see those patients have other sensations such as pain, burning, stinging, and prickling. And those are all, if you look at the numbers, more than 50%. And some patients, they actually describe that an itch that is just so excruciating, right? One patient said, I have no desire to meet up with anyone. I only talk to a few people on the phone that know my condition. It's quite sad, and you see that's quite depressing, and these patients certainly have emotional issues. Now, also, you look at those lesions. These are typical prurigo nodularis patients. You see papules, nodules, plaques, ulcers, different lesion types. Again, you see different morphology here, and you see the differences between different skin colors. In the darker skin patient, you can see the severe hyperpigmentation, but also severe hypopigmentation right next to each other. It's pretty amazing. And you see the different lesion, the morphology changes also from skin type, as well as from patient to patient here. And the fact that you can have different lesions coexist at the same time, sometimes it might be challenging to diagnose PN. The other interesting finding, and I really did not know this, now this comes from a small study, I believe it's about 600 patients or so in Baltimore, Maryland, and it might be maybe a little bit of a skewed population. I think it was 909 patients. I'm so sorry, not 600. 909 patients, and it might be a skewed population. However, when you look at those numbers, the odds ratios with atopic derm is pretty high, 72.2, which I think I agree with that. I've seen it. But what's interesting is you have HIV, chronic hepatitis, chronic kidney disease, pretty up high there, especially HIV. And I was surprised. Again, I'm not sure if it's a skewed population, and that's why we see this high numbers, especially with HIV and chronic hepatitis C, or maybe if you go across the board, across the US, you might see different numbers. But the bottom line is that those patients have comorbidities anywhere from 38 to 50% of the time, have systemic conditions. And honestly, I don't want to play primary care doctor. I've said this several times, but it's important to recognize those problems that they may have. And it might be a good idea to refer them to their primary care doctor just for an overall general checkup, especially those that might have CHF, COPD, diabetes, right? I think it's important. Again, I don't want to diagnose or treat these conditions, but I think it's important to be aware that to send them for appropriate diagnosis or treatment. And I think we know from the clinical studies that atopic derm and asthma are common in this population with PN, and we've seen this in the clinical study numbers. So basically, when you look at quality of life and severe itch with skin inflammation, skin lesions and nodules, the patient burden we see on the surface, but then there is, I think, much deeper. It goes much deeper than that, with the negative social impact, increased rate of anxiety, depression, significantly impaired quality of life, sleep disturbance, which may lead into financial loss. So the patient burden, I think it's very heavy on those patients. I think both AD as well as prurigo nodularis. And the reason for that adds up not only this inflammation or inflammatory nature of the diseases, but also the severe itch, especially the severe itch that leads to all these negative influences. So the next question is, what drives the itch in those two diseases, in atopic derm and prurigo nodularis? And that's the exciting part. I think so far we sort of have an overview of both conditions and the impact of those conditions on our patients. But I think it's going to be really interesting what drives the itch and what is this bridge that puts those two diseases together. So this is a very, very exciting and a diagram. I really like it. I think it's quite simplified. I was part of this creating and helping the slide deck a little bit, and I think this is a really final version. And here what we see is, and this is both immunology and a little bit neurology here. What we see, there are four pillars, right? There are four pillars here. We're talking about pruritus, inflammation, barrier dysfunction, and fibrosis. So let's start from inflammation because we are very familiar with Th2 pathway. We know that Th17 pathway belongs to psoriasis and Th2 pathway belongs to atopic derm. The cells that are involved, the immune cells that are involved, are basophils, eosinophils, macrophages, dendritic cells, but also mostly the Th2 cells. Now, Th2 cells, they release cytokines IL-4, IL-13 that we are familiar with because we have now we have biologics that targets those cytokines, right? We also are familiar with now IL-31, and this is basically those cytokines create inflammation. They, I should say, facilitate also pruritus. Then they impact certainly the keratinocytes, and the keratinocytes, they got impaired and they unfortunately end up with the part of becoming the problem with barrier dysfunction. And then we have other cytokines released by keratinocytes, IL-25, IL-33, by the way, TSLP. And then in return, we have other cytokines involved, such as IL-33, periostin, and chemokines that actually activate the fibroblasts and create the fibrosis or the causing lichenification and scarring. Now, if you noticed, I totally left the very first pillar, pruritus, alone because I thought that it would be easier for us to start with the familiar part of the disease and then go to the sort of the new part here, the sensory nerves. The sensory nerves have receptors, IL-13, IL-14, and also IL-31 receptor alpha. Now, keep in mind the IL-31 receptor alpha here will be very interesting, and we will keep emphasizing and mentioning that receptor since we're learning new about it. It's sort of a new information, and it is on the sensory nerves, and actually it's all the way up to the dorsal root ganglia that we will go, and we will learn a little bit more. So this is an overall picture, and we're gonna go for each pillar one by one in depth. So here, as we discussed, this itch and connects those immune mechanisms and the neuronal mechanisms, right? The itch signals are transmitted to the CNS from the skin via sensory neurons, and the elongation and branching increases the sensitivity of neurons. And then the neuropeptides, by the way, I didn't mention that on the previous slide, just like substance P and calcitonin gene-related peptide contribute to itch as well. Then on the other side, we have the immune mechanism. The immune cells are involved: eosinophils, basophils, macrophages, mast cell, Th17 cells, Th2 cells, and we know that Th2 cells play a role in atopic derm. Specifically, Th17 cells play a role in psoriasis, but sometimes they go back and forth and cross-react certainly. But what is that bridge? What is that bridge that actually stimulates the itch? And that's where IL-31, cytokine IL-31 comes into the picture. And that's where IL-31 receptor alpha becomes important. So where are they? So who produces the IL-31? Well, we have Th2 cells, we have basophils, mast cells, macrophages, eosinophils, dendritic cells. So basically, the immune mediation of IL-31, which goes and binds to IL-31 receptor alpha. By the way, the other side of the dimer is the oncostatin N receptor beta chain, but at this point, it's not relevant. We're just going to focus on that IL-31 receptor alpha, right? So we discussed that the immune system, the immune cells are producing the IL-31. What's happening? They are going and binding to IL-31 receptor. But who has the IL-31 receptor? So again, immune cells, dendritic cells, basophils, eosinophils, keratinocytes on the skin as we discussed, as well as fibroblasts. But also sensory nerve endings have IL-31 receptor. And that's where the IL-31 is binding, create that all that vicious itch and scratch cycle. It stimulates pruritus, the all sensory nerve endings. Now I'm gonna remind you something, right? In the old days, my my professors, when I started almost more than 30 years ago doing my residency, they used to call atopic derm that it's not a rash that itches, it's a itch that rashes, right? So that itch comes first. And also, as we all know, even though we use a lot of oral antihistamines for atopic derm, we know that oral antihistamines don't work for atopic derm itch, right? Because what we're dealing here with non-histaminic nerve fibers. Because they are non-histaminic, no matter how much oral antihistamines you give, they're not gonna work. So here now, I resemble this to Brooklyn Bridge. So the Brooklyn Bridge here between the neuronal mechanism and immune mechanism is IL-31. That's what's happening. IL-31 bridges the gap between the mechanism of itch and inflammation, or between the neuronal mechanisms and the immune mechanisms. So I think that makes it very clear the role of IL-31 both in atopic derm and prurigo nodularis, bridging those two diseases. Then IL-31 is the direct driver of the itch. As I mentioned, the sensory nerve endings demonstrate high IL-31 receptor alpha, and IL-31 stimulation leads to nerve elongation and branching, as well as dorsal root ganglia. We see the same thing. And basically, these itch sensory neurons, that they have this, not only the IL-31, but IL-4, IL-13, but in this case, mainly the IL-31 receptor alpha, where IL-31 binds and basically creates the whole that itch scratch cycle. And so IL-31 directly drives the itch signaling, which may be due to enhanced expression of IL-31 receptor alpha in the dorsal root ganglia as well. So it's not only the sensory neurons, but it's also the dorsal root ganglia. Now, how about if we go back to the inflammatory pathway and IL-31 role in the inflammatory pathway in the type 2 inflammation, right? So when we look here, we see that IL-4 and IL-13, by the way, we're familiar with those two cytokines, right? That's because they are secreted downstream from the IL-31 stimulated basophils, and thus positioning IL-31 as an early upstream during the development of the type 2 skin inflammation. So what you see here, the basophils basically releasing the IL-13 and IL-4, and they stimulate the Th2 pathway, but the Th2 in return also releases more IL-31, and the IL-31 does stimulate that basophils and eosinophils, right? So it is, again, a positive loop here. And just remember what I said earlier about the oral antihistamines and non-histaminic fibers here. So how about the barrier function, right? The barrier function is a big problem in atopic dermatitis. Mostly some atopic dermatitis, especially I should say, they have genetic deficiency of filaggrin, which certainly contributes to the barrier dysfunction. The pH of the stratum corneum certainly contributes to the barrier function, right? In the old timers, they used to call the acid mantle. You need that acidic pH in order to maintain that stratum corneum's barrier function, because it does, the pH plays an important role in the enzymes, in the creation of the lipids, as well as in the breaking down of the corneodesmosomes that they hold the keratinocytes together, and that's all pH dependent. If the pH, you wash your hand with tap water, the pH is neutral now, and that creates a perfect environment to break down that barrier, to break the corneodesmosomes, as well as not making enough lipids. And then you use hand soap, which is all basic. Now you're going up to pH of 9, and it becomes you create that perfect storm and perfect environment for barrier dysfunction. And then you have IL-31 stimulation, which disrupts the normal keratinocyte differentiation, leading to the atypical skin development and the barrier dysfunction. So that is like the perfect storm here, more than one thing happening. But the role of the IL-31, again, it's basically disrupting the normal keratinocyte differentiation, which becomes a problem during the barrier function, right? And creates the barrier dysfunction. Then you increases transepidermal water loss. By the way, that is the measure of the barrier function, or I should say indirect measure of the barrier dysfunction, right? And you start losing the water. It evaporates through the broken barrier, and all the problems start following one after another: the itching, the scratching, and the inflammation. Now, with that said, how about the fibroblasts? So that is the last pillar that we had discussed, right? The fibroblasts also plays an important role here. They produce collagen, they play a role in tissue remodeling, chemokine and cytokine, increased chemokine and cytokine expression. With the increased IL-31 receptor alpha expression, the fibroblast again enables the IL-31 signaling, and it increases the inflammatory response and tissue remodeling, and hence the lichenification. Think about the lichenification just like scar formation or just like keloid formation. That's exactly the same concept. That's what's happening in atopic dermatitis. Okay, so we're back, we're home to the very first slide that I showed you, the 4 pillars, or they called it 4 hallmarks of atopic derm and prurigo nodularis here, right? So we have the pruritus. Now I am not gonna go to the middle, I'm gonna start from the prurigus to summarize it, where IL-31 directly drives the itch signaling and binds to the IL-31 receptor alpha on the nerve endings and dorsal root ganglion, which creates the inflammatory cycle with the IL-31 also creating Th2 cell and the release of the IL-4, IL-13, and other inflammatory cytokines, impacting the keratinocytes, and then eventually the fibroblasts, causing the fibrosis and the lichenification, and also impacting negatively the barrier function. So, what were the most surprising learnings about the role of IL-31 in AD and PN? I think the whole thing, to me, it's surprising. I did not know most of this. This is all new information that I really appreciate, and this is gonna lead us to a whole new treatment paradigm. So when we look at the patient treatment goals, right, this is very interesting. First, let's take a look on the proportion of the patients indicating their treatment expectations were met. Unfortunately, most is partially met, right? 69 to 74% take it, and this is both across both less than 10% BSA or more than 10% BSA, body surface area, right? Regardless I should say size of the disease, regardless the body surface area, really most of the patients, around 70% of the patients, they think that their expectations are completely met. And part of it goes back to the original, that heterogeneity of the disease that we discussed, those tables, that the correlation between the lesion severity versus the itch severity, that unfortunately we only take into consideration the lesion severity as providers. And I think the patient's expectations will be met when we take their symptoms, the itch especially, into consideration, and not only the lesion severity. And the fact that the severe itch, even it's with mild or moderate lesional severity, is considered severe disease by the patient, has a lot to do here, what we do, or I should say what we don't do for our patients, unfortunately, and that's why their expectations are partially met. And when you look at what they really want, their treatment goals is itch-free, better sleep, regain control of the disease. They want everything in reality. But I think the itch-free becomes here number one. Ironically, you don't say lesion-free, right? You don't see here lesion-free. You see better skin quickly. Everybody wants a quick result. Unfortunately, in this country, we are very spoiled, but that's how it is. But really, the itch-free and better sleep is very important. And again, it's important for us to realize what the patient's expectations are, but we're not going to realize that until we listen to them and until we take the itch severity into consideration, regardless of the skin lesions. And very similarly, Prurigo nodularis is the same. Sleep disturbance is important, daily life, relationship, social life, basically everything is really important here on that survey. One patient says, I wake up 3 or 4 times a night, even when I take sleeping aids. A lot of times I am waking up scratching. And we hear this all the time. So how do you monitor treatment success in your practice? You know, I'll tell you, I used to be very much so visual and looking at the patient and decided myself. And but as I'm getting older, I think I'm listening more and more to the patients. My dad had nothing to do with medicine. He had a business, but in his store on the wall, the first thing you saw when you walked into the store, the first thing he saw, he had a sign. And when you translate it, it came out, it says basically the customer is always correct. So the customer in this case is really the patient, and the patients are not necessarily always correct in this case, but I think it's important to listen to them and take things such as itch into consideration. And so now I ask the patient, how are you doing? And if they say, I'm fine, doctor, then I'm fine. I leave them alone. I don't push more treatment. I have patients who come to me and some of them are covered maybe head to toe, and they say, hey, I need another 1 pound jar of triamcinolone. And okay, if that's what they want, even though I do give them more options. And then I have some patients that they have very small body surface area, but they want the most aggressive treatment. So it all depends. Before the pandemic, in one of the EADVs, I presented a program that discussed basically how patients self-perceive. And that self-perception of the patients depends on many different values, right? Their financial standing, social standing in the society, their religious beliefs, how they see their own healthcare. So there are so many factors that goes into that equation, how they perceive themselves, how they perceive their disease impacting them versus how we see them and how we see their disease impacting them. And sometimes it's very, very discordant. So the bottom line here is that we have two diseases, atopic dermatitis and prurigo nodularis. They both are chronic inflammatory skin conditions with a huge burden of disease. But also they are not only inflammatory, but they are also neuroimmune diseases that in this case, the itch is the central to the pathophysiology and is reported by the patients to be the most burdensome symptom. And in this pathogenesis, we have many cytokines that play a role, including IL-4, IL-13, IL-31, TSLP, and maybe many more that we still don't know and we will learn. And those cytokines, especially IL-31 here, it plays an important role, itch and inflammation, neuroimmune bridge, I would call the interactions in the atopic derm and prurigo nodularis. And IL-31 itself is a neuroimmune inflammatory cytokine that bridges the gap between neuronal and immune mechanisms, atopic derm and prurigo nodularis. And I think I will stop here. And I thank you very much. And we have, I think, some time for questions. And I'm going to take a look here if we have some questions. So bear with me since I'm both the moderator and the speaker, I'm gonna do my own questions here. So one comment came, it's very interesting. I feel like I see a lot of prurigo nodularis in patients with chronic kidney disease. It's a very good point. We discussed that yeah, this comorbidity exists quite a bit. So so it's really important that that's a good comment. Thank you. The next one is, how do you address severe pediatric cases both in lesion severity and in patient symptomology, but the parents are minimalist in terms of treatment, specifically they prefer no systemic medications, and you feel that the young patient would benefit greatly from such treatment, etc. Yeah, it's a really good question. It's a difficult one to answer. I think everybody's situation is a little bit different, and the patients, and sometimes you need to, I think we need to spend a little bit more time in the room and discuss the patient. But at the end of the day, you know, the parents make the decisions for the kids, like it or not, and we have to go along with that. Another comment is that just want to outline and highlight the role of the allergists and immunologists, as atopic dermatitis has a lot of atopic comorbidities, including asthma and allergic rhinitis. Absolutely. I think what I say, co-management of atopic dermatitis, both by dermatologists, allergists, immunologists, sometimes even pediatrician, is very, very helpful. I certainly don't want to play any of those roles other than dermatologists, especially I don't want to handle people's non-cutaneous allergies or especially asthma. So absolutely, it's important. Now I have some other questions here. So do you think phenotypic heterogeneity that exists in atopic dermatitis contribute to diagnosis delays? You know, that's really a good question in the sense that when there is different morphology, we may all fail diagnosing it appropriately. I do quite a bit of teaching during the clinical trials. We have, you know, training of the investigators, right? To make sure that everybody is sort of familiar with how to do the IGA, how to do the easiest score, and all that. And it's not as easy. It's very subjective how to rate those lesions and the disease severity. You can take 100 experienced investigators and you don't get the same answer. We get close, but not exactly the same. And that happens over and over. Now, having said that, that might also the differences, especially in darker skin, If one is not experienced in assessing darker skin, it becomes really difficult even to assess erythema. It becomes grayish, purplish, bluish hues, different. Sometimes it's only post-inflammatory hyperpigmentation that it's ranked as erythema. So absolutely, whoever asked the question, yeah, absolutely correct. That's basically is difficult to identify sometimes. Besides itch, what are the other top burdens and symptoms shared between the patients with AD and patients with PN? I think, again, asthma is one of those, the lesional severity, but I think the sleep disturbance, right, is another one. The sleep disturbance is a big problem, mostly led by pruritus. And then probably the lesional severity is a problem, but on the comorbidity side, asthma um, and um, and the sleep disturbance, I believe, are important. Are the criteria for diagnosing a patient with PN well understood? How is PN differentiated from other itchy skin conditions? Really good question, but I think PN has pathognomonic, that's prurigo nodules, right? I wish we could go back to the original, one of the original slides that has the diagnosis and the manifestations of PN, but you do want to have that certain amount of the pruritus period, 6 weeks or more. And again, when we do the clinical studies, there's a whole inclusion criteria. Most of the lesions are symmetrical on both legs or both arms, and they are sometimes elevated. They are sometimes papules. They are smaller, but I think it's quite pathognomonic. You see that these nodules. In AD and PN pathophysiology, do each of the 4 pillars, itch, inflammation, barrier dysfunction, and fibrosis, contribute equally to driving disease, or does one drive the pathogenesis? Well, I think they all equally contribute to the disease itself. But I think, as we saw, itch as the burden on the patient, right? It's very heavy, but also the itch that's caused by IL-31, and IL-31 as the that bridging cytokine between both nervous system and the immune system becomes important, as it's a neuroimmune disease in this case. And I think, again, I cannot emphasize enough to understand that pathway, because I think it is quite new for us in dermatology. And just like 20 years ago, when we were trying to learn the Th17 cells for psoriasis, we will have some time, I think, evolve and learn all that. Having said that, I think we are close to our time, and I really thank everyone for attending this evening, and hopefully it was beneficial, and hopefully everyone learned something new. I'd like to thank to our supporter Galderma again, and now that we are done with the Galderma program, I'd like to invite you August 13, basically in less than a week, next Tuesday night at 7 p.m. We have an exciting program, Protexidin, a first-in-class technology. It is about to prevent premature aging, and it's going to be presented by Dr. Naim Issa as well as Steve Hernandez from Topics. I thank you so much for your attendance, and I wish you a good night.